Welcome to my lecture today on thyroid disorders. Thyroid disorders are very common subject for examination in theory and clinical exam for medical students. Okay, we start off with the anatomy of the thyroid gland, and first some short notes about embryology of this development of the thyroid gland, which develops at the base of the tongue. The thyroglossal duct develops from the median bud of the pharynx at the base of the tongue. The foramen cecum is the vestigial remnant of this duct. The thyroglossal duct goes down very near or through the developing hyoid bone, and the parathyroid glands from the third and fourth pharyngeal pouches accompany this descent of the thyroid, together with the thymus from the third pharyngeal pouch and the ultimobranchial bodies, which form the parafollicular or C cells of the thyroid. Okay, this is a diagram to show you the third pharyngeal pouch, the fourth pharyngeal pouch. Third pharyngeal pouch gives rise to the inferior parathyroid glands. The fourth pharyngeal pouch gives rise to the superior parathyroid glands, and the ultimobranchial body from the fourth pharyngeal pouch forms the parafollicular cells of the C cells of the thyroid. Okay, the thyroid gland originates between the first and the second pharyngeal pouches. Between the first and the second pharyngeal pouch, somewhere at the base of the tongue. Okay, in the third week of gestation, around day 20 to 24, endodermal cells of the primitive pharynx around here proliferate, creating the thyroid diverticulum, which continues to descend inferiorly to the region of the trachea. As it descends, it combines with glands from the fourth pharyngeal pouch, which is the superior parathyroid, and the ultimobranchial body. The ultimobranchial body gives rise to the C cells or the parafollicular cells. The third branchial pouch gives rise to the inferior parathyroid glands and the thymus. Okay, so as the thyroid descends down to the larynx and the tracheal region, these also join together to its final position in the pretracheal area. The thyroglossal duct marks the direction of the descent of the thyroid. Okay, the thyroglossal duct there from the base of the tongue, the region of the foramen cecum, it descends down through the hyoid bone and then in front of the larynx, and then finally to the upper trachea and in front of the upper trachea. Here again, as it descends, sometimes it can have cystic remnants along its track, and these are known as the thyroglossal cysts. So that the path of descent is foramen cecum, hyoid bone, larynx, and trachea. Next, we come to the anatomy of the thyroid proper. Okay, you can see the thyroid consists of two lobes and a middle lobe known as a pyramidal lobe. There are four glands, the parathyroid gland, the superior and the inferior, which are closely related to the upper and the lower lobes respectively. Then there is the other important structure that passes through the gland, actually between the trachea and the esophagus, esophageal-tracheal groove. This is the recurrent laryngeal nerve, okay, on either sides, the right and the left. Okay, the two lobes are joined together in the center by the isthmus. Okay, the location of the thyroid is in the lower part of the front and side of the neck, opposite C5 to T1 vertebra. Each lateral lobe extends above from the thyroid cartilage to below the fifth or the sixth tracheal rings here. And the isthmus crosses the midline in front of the second to fourth tracheal rings. Okay, now we come to the arterial and blood supply and the venous drainage of the thyroid gland. Okay, as you already said, the thyroid is located in the anterior intramuscular triangle of the neck. Two lobes, right and left, connected by the isthmus overlying the second to the fourth tracheal rings. And there's also a pyramidal lobe in many patients. It weighs 20 to 25 grams and normally it is not palpable. If it is palpable, then it's considered enlarged. Okay, the arterial supply are three: superior thyroid artery from the external carotid artery, the inferior thyroid artery from the thyrocervical trunk of the subclavian artery, the thyroid artery to the pyramidal lobe, and there's extensive arterial anastomosis with branches to the tracheal and esophageal arteries. So the main one here you can see the superior thyroid artery from the external carotid. Then you've got the inferior thyroid artery coming from the thyrocervical trunk on either side. Then sometimes you have thyroidal artery and extensive anastomosis around here. Okay. As for the venous drainage, also follows the arterial supply. The superior thyroid artery accompanied by the vein here, which enters into the internal jugular vein. Then there is the middle thyroid vein, which also enters into the internal jugular vein. And here is a inferior thyroid vein, which drains into the left innominate or brachiocephalic vein. Okay, so three veins and two arteries. The lymphatic drainage of the thyroid and neck is very important. Okay, so this picture shows you the various levels of lymph nodes. There are 7 of them: 1, 2, 3, 4, 5, and 6, and 7. Okay, now most of the lymph from the thyroid drain into the juxtathyroid Delphian lymph nodes or the paratracheal lymph nodes, which is shaded in blue here, shaded blue. This is the visceral lymph nodes or the Delphian lymph nodes in this area. Then this level 1 is the submental and submandibular lymph nodes. Level 2, 3, and 4 are the deep cervical nodes, upper, middle, and lower. And this is the posterior triangle lymph nodes. Okay, so all these lymphs will finally drain into the deep system. Some lymphatics from the thyroid drain directly into the deep cervical nodes. Okay, this picture shows you the layout of the cervical lymph nodes. Level 1, submental and submandibular. Level 2, level 3, and level 4 are the deep cervical lymph nodes or the jugular lymph nodes, upper, middle, and lower. Then you have level 5, which is the posterior group of lymph nodes, posterior triangle, and level 6, the anterior group or the visceral lymph nodes, which occupies the visceral space where the thyroid is located. So lymphatics from the thyroid drain predominantly into level 6 lymph nodes. And level 7 is the inferior infraclavicular lymph nodes or the mediastinal lymph nodes. Okay, the most important nerve in the neck is the vagus nerve, which is cranial nerve number 10, as shown in this diagram here. Okay, this is the vagus nerve. Okay, there are three main branches: superior laryngeal here, superior laryngeal, which enters the larynx high up in the neck here, okay, superior laryngeal. Then the most important recurrent laryngeal nerve, okay, this is the recurrent laryngeal nerve, okay, which on the right side, it loops around the right subclavian artery and then goes upwards in the, it's a tracheoesophageal groove and enters the thyroid. Then the left recurrent laryngeal nerve, also in this case, it loops or winds around the arch of the aorta before entering the tracheoesophageal groove and then going upwards into the larynx. Okay, the recurrent laryngeal nerve is a very important nerve which must be studied with care. Okay, this picture shows you the recurrent laryngeal nerve here. This is on the right side and this is on the left side. Okay, it runs along the tracheoesophageal groove, enters the larynx at the level of the cricothyroid joint. Okay, the cricothyroid here, at the level of the cricothyroid joint here. Okay, where ligament called the Varis ligament attaches the pretracheal fascia to the thyroid. The recurrent laryngeal nerve innervates all the intrinsic muscles of the larynx and sensation to the larynx below the vocal cords. So below the vocal cords, innervated by the recurrent laryngeal nerve. Okay, now we come to question number 1. The thyroid gland is derived from the third and the fourth pharyngeal pouches. B. Isthmus overlies the fifth and sixth tracheal rings normally. C. Embryologically descends along the thyroglossal tract. D. Is supplied by the superior thyroid branch of the internal carotid artery. And E. Is supplied by the inferior thyroid branch of the external carotid artery. Okay, and the answer is C. Embryologically descends along the thyroglossal tract. Okay, question number 2. The 4 small glands in the thyroid gland are known as A. Adrenal glands, B. Pineal gland, C. Parathyroid gland, and D. Endocrine and exocrine gland. And the answer is C. Parathyroid gland. Okay, next we come to another important aspects of thyroid gland, the physiology. Okay, the thyroid gland is an endocrine gland. The functional unit of the gland is called a lobule, and each is supplied by an arteriole. The lobule consists of 24 to 40 follicles, and these follicles are lined by cuboidal epithelium. The processes that take place in these follicles are trapping of inorganic iodide from the blood, oxidation of this iodide to iodine, followed by binding of this iodine to amino acid tyrosine to form monoiodotyrosine and diiodotyrosine. And the next is your coupling to form the triiodothyronine and T4 thyroxine. And these coupled T3 and T4 are bound to thyroglobulin and stored in the colloid. Okay, this is a slide to show you the picture. This of all this. This is your lobule, consists of numerous follicles. Okay, here you see the follicles are lined by each lobule consists of 25 to 40 lobules, follicles, and each follicle is lined by cuboidal epithelium, and which contains the lobule itself, follicle itself contains colloid. Okay, this is what I told you, the processes that take place. This is the bloodstream, this is the follicular cell, and this is the colloid within the follicle. Okay, iodine, the first step is the trapping of the iodine from the blood, and this is known as trapping of iodine. And this then next is oxidation of the iodide to iodine, and this is called oxidation. And this oxidase iodine then bind to tyrosine on the thyroglobulin molecules, and this is known as binding. And then next process is called coupling, where the MIT monoiodotyrosine and the diiodotyrosine combine, couple to form your T4 and T3. And then this is then stored, attached to thyroglobulin and stored in the colloid. When is required, it is excreted back into the bloodstream by a process of endocytosis and proteolysis and released as T3 and T4 in the bloodstream. The T3 and T4 are extracted from the colloid and excreted into the blood, as I said, and in the blood is mainly bound to serum proteins, and these proteins include albumin, thyroxine binding globulin (TBG), and thyroxine binding prealbumin (TBPA). Okay, so these are the proteins that carry the thyroxine T3 and T4 throughout the body. The total serum T3 and T4 are affected, therefore, by serum protein levels. More important, biologically active free T3, which is 0.03% of the total T3, its action is within hours. It's rapid, very fast action. That is T3. T4, 0.3% of total serum T4 is converted to T3, and this takes the action of this takes 4 to 14 days. So you can see T3 is faster action compared to T4. Now the other group of cells in the thyroid, known as the parafollicular or C cells, secrete calcitonin, which is a tumor marker for the recurrence of medullary thyroid carcinoma. Okay, now the regulation of thyroid function. Okay, this is a chart to show you the thyroid physiology and the regulation of thyroid functions. Okay, the hypothalamus secretes the hormone known as TRH, thyrotropin releasing hormone, TRH. Okay, then this stimulates the anterior pituitary to secrete thyroid stimulating hormone, TSH. Okay, and that, the anterior pituitary, and that produces TSH. So TRH stimulates anterior pituitary to produce TSH. And this TSH controls the synthesis of T3 and T4. And so it increases the production of T3 and T4, which are then carried to all parts of the body. And a higher level, and there is a feedback modified by negative feedback mechanism. Okay, the higher the level of T3 and T4, has a negative feedback on the hypothalamus as well as the pituitary. So thereby, it reduces the production of TSH and subsequently the T3 and T4. Okay, this is the summary. Hypothalamus releases TRH, stimulates anterior pituitary to produce TSH, which stimulates the thyroid to release T3 and T4. And these two, T4 and T3, have got negative feedback on the anterior pituitary as well as the hypothalamus. Okay, now we come to question number 3 on physiology. Okay, the main hormone secreted by the thyroid gland: A, T3, T4, B, T3, C, A and B both, D, TSH. The answer is C, A and B, both T3 and T4. Question number 4. Iodine deficiency can cause goiter: A, goiter, B, thyroid cancer, C, solitary thyroid nodules, and thyroiditis. The right answer is goiter, A, goiter. Okay, next we come to the investigations of thyroid disorders. Okay, first blood test, as I said, thyroid function test and TFT, which includes TSH, T3 and T4. It also the level of thyroglobulin levels, calcitonin levels, and if you suspect autoimmune thyroiditis, then autoantibodies levels in the blood. Chest X-ray, chest and neck must be done in these patients, especially large tumors, large goiters. Ultrasound neck is the most important first-line investigation for thyroid problems. CT scan, especially if tumor is suspected. Then the others include radioisotope scan, radioiodide isotope scan, FNAC, fine needle aspiration cytology, is very highly sensitive and specific, more than 90%. And thyroid sequencing, gene sequencing analysis, which is a genetic test which is done in some high sophisticated or complex centers. Okay, these are the investigations. Thyroid stimulating hormone, TSH, is essential. If normal, then no need to check for free T3 and T4. Free T3 and T4 only if TSH level is abnormal. Okay, this table here shows you the normal levels. Euthyroid normal, TSH normal, free T4 normal, free T3 normal. Thyrotoxic, TSH undetectable, whereas T4 and T3 are high, elevated. Mixed edema, that is hypothyroidism, TSH is high and the hormones are low. And this is an important one, suppressive T4 therapy, TSH is undetectable, T4 is high, and T3, free T3 is usually high but may be normal. Antithyroid antibodies against thyroid peroxidase and thyroglobulin for the diagnosis of autoimmune lymphocytic thyroiditis. So this is an important test if you suspect autoimmune as a cause of your thyroiditis. Okay, thyroid imaging consists of chest X-ray, which I mentioned, including the thoracic inlet, where you can see a widening of the superior mediastinum. Can you see here? Widening of the mediastinum, which tracheal compression and deviation of the trachea. Okay, here again, a mediastinal tumor here, which is a goiter, retrosternal goiter, which causes pressure on the compression on the trachea or bronchus. Okay, this is an ultrasound scan. It gives good image of the thyroid and the regional lymph nodes around the thyroid, and also useful in needle biopsies where you can obtain a more targeted needle aspiration for cytology when you do it under ultrasound guidance. Next investigation would be CT scan. Okay, here you can see a large thyroid swelling here at the thoracic inlet. Others include MRI and positron and PET for selected cases, example known malignancy, retrosternal goiter or recurrent goiter. Okay, isotope scanning, not routinely done, cannot distinguish between benign and malignant, uses low dose radioactive iodine or technetium-99, localization of hyperactivity is the main use of isotope scanning. It can detect whether the nodule or the lesion is hot or cold nodule. Okay, hyperthyroid patient with single nodule, toxic nodule. Nodularity, toxic nodular goiter. Whole body scanning to locate the distant metastasis after total thyroidectomy. Yeah? That is another indication of radioisotope scanning. Yeah? After thyroidectomy for carcinoma, you do this whole body scanning to locate for bony metastasis, especially bony metastasis. Okay, here this is a normal thyroid radioisotope scan. Graves' disease increase and tremendously increase intake of iodine. This is your multinodular goiter, toxic. Okay, increase uptake here, dark areas here. And this is a nodule which is toxic adenoma, the increased uptake of radioiodine. Okay, and this is a picture to show you the fine needle aspiration cytology. Here, patient is lying supine, with the neck extended, with the ultrasound probe and a needle to aspirate the nodule or the lump. And that is sent for cytology, and the results are as follows. Thy 1 to Thy 5. Thy 1 is non-diagnostic and Thy 5 is malignant. 2, 3 and 4 are various grades of benign to malignancy. Okay, fine needle aspiration is the investigation of choice for discrete thyroid swelling. It's a simple, quick, good compliance and readily repeated and an outpatient procedure. Routine diagnostic procedure for thyroid swellings. And ultrasound guide and when done under ultrasound guidance improves the accuracy of aspiration. Now we come to question 5. Which of the following is the most precise diagnostic screening procedure for differentiating benign thyroid nodules from malignant ones? Answer A, thyroid skin T scan. B, thyroid ultrasonography. C, thyroid hormone suppression. D, fine needle aspiration biopsy. And the right answer is D, fine needle aspiration biopsy, FNAB or FNAC. Okay, next we'll go through some important diseases of the thyroid gland. The first is called goiter. Okay, goiter is actually an enlargement of the thyroid gland. Normal thyroid gland is not palpable. So if it's a goiter, then it is palpable. There are two types of enlargement of the thyroid gland or goiter. Is general enlargement of the thyroid gland, called diffuse goiter, or a discrete nodule. That means just a nodular goiter. It can be discrete, solitary or isolated nodule, and the rest of the gland is normal. Or it can be a dormant nodule in a multinodular goiter, where the rest of the gland is abnormal. Classification of thyroid goiters will be a simple goiter, toxic goiter when it is hyperfunctioning, thyroid nodule, solitary or cystic, solid, toxic and non-toxic, neoplastic goiters or malignant goiters, and inflammatory goiters such as thyroiditis. Okay, now we come to the simple goiter, which is usually euthyroid. What are the causes? The first cause is caused due to lack of iodine or defect in the thyroid hormone metabolism. So this decrease in synthesis of the thyroid hormones leads to a chronically low levels of thyroid hormones. Thus, there's increased DHA secretion that causing overstimulation of the thyroid gland. And this is usually the case in endemic goiters. Second is a adenoma of the anterior pituitary gland, which causes an increased secretion of TSH. And this can also cause goiter, but is rare. Then other goitrogens and all the other substances that can cause goiter. Calcium, thiocyanates in cabbages and other vegetables, para-aminosalicylic acid, PAS, anti-thyroid drugs, carbimazole and thiouracil, and iodides in large amounts. Okay, now we come to the pathogenesis of simple goiter. Okay, what happens in how does simple goiter come about? Okay, as I said, there's persistent growth due to TSH stimulation of the thyroid gland. Okay, so initially the gland, there's a diffuse hyperplastic enlargement which is reversible. Subsequently, there's chronic fluctuating stimulation leading to mixed pattern of active and inactive nodules. When there are also the fluctuating levels of TSH causes increase and decrease activity of the thyroid gland, and this causes hemorrhage and necrosis inside the active nodules, lobules, and necrosis. These necrotic nodules join together to form nodules filled with iodine-free colloid or new inactive follicles, and which finally become multinodular goiter, which is an irreversible stage. In this stage, the nodules are inactive and active follicles found in the internodular tissues. Okay, now this is the pathway. TSH stimulation persistent causes diffuse hyperplastic goiter, which is reversible. Then, due to the chronic fluctuating stimulation of by TSH, the thyroid nodules are formed, colloid nodules are formed, and these colloid nodules enlarge. Some of them become necrotic and join together to form multinodular goiter, which consists of active and inactive follicles within this substance. In fact, as time goes, more and more follicles become inactive. And this is an irreversible stage, which can be shown clearly seen in the next page here. This is a diffuse hyperplastic goiter. It's the early stage, which is reversible. And this usually occurs in younger people, children, and even in puberty in sporadic cases. May enlarge with pregnancy. And this diagram here is a case of a late stage nodular goiter, multinodular goiter, which is irreversible. Okay, these are the two stages of in the formation of multinodular goiter. Okay, what is multinodular goiter? Multinodular goiter is an enlarged thyroid gland with multiple nodules which are irreversible. That means that cannot go back to normal. Okay, this is a histological pattern, gross anatomy, and this is a clinical picture. Usually they are clinically euthyroid. Okay, there can be transient mild hyperthyroidism in 30% of cases. Usually painless, smooth, firm, and mobile. Irregular and hard goiter may be due to calcification in some cases. These patients sometimes may be due to autoantibodies, so these patients must be subjected to autoimmune antibody studies. Thyroid function tests, chest X-ray, and ultrasound are the most common investigations for multinodular goiter. If there are pressure symptoms or if they are suspicious of malignancy, then a CT scan is necessary. Painful or sudden enlargement of one of the nodules may be due to hemorrhage or carcinoma, which is usually follicular carcinoma. So multinodular goiter is usually painless and progressively increases in size. If there is a sudden increase in size or suddenly it becomes painful, you must think of hemorrhage or malignant change. And multinodular goiters can be diagnosed, these cancers can be diagnosed by doing a FNAC for these patients. Now, what are the complications of multinodular goiter? Hemorrhage, secondary thyrotoxicosis, malignant transformation. Rarer ones will be calcification, cyst formation, retrosternal extension, infection, and pressure symptoms. Okay, this is a patient with a retrosternal goiter where there is inlet of the thoracic inlet is obstructed by an extending goiter into the mediastinum, and usually arises from the lower pole of the multinodular goiter. Rarely it arises from ectopic thyroid tissue. Patients can be symptomatic or can be asymptomatic and found on routine chest x-rays. Common symptoms will be dyspnea, cough, stridor, dysphagia, congestion of the veins if there is obstruction of the thoracic inlet, especially over the neck and the upper chest wall. Rarely it causes recurrent laryngeal nerve injury, and these patients, all of them, need chest x-ray and CT scan of the neck and chest. Treatment is usually thyroidectomy, and most cases are amenable to the usual cervical approach. In large cases, sometimes you may need to do a median sternotomy as well to remove the extended goiter. Okay, sometimes in some patients when there's an early enlargement, you can have what you know as prophylaxis to prevent the development of the cancer to multinodular goiter. So in these patients, you can give them iodized salt in endemic areas where there's deficiency of iodine, or give them thyroxine supplements 0.15 to 0.2 milligrams daily for a few months. So in early stages, this may suppress the TSH and lead to regression of the swelling. In general, the treatment of multinodular goiter, in most cases, is if asymptomatic, no treatment needed unless for cosmetic reasons. More than half of benign nodules will regress over 10 years, okay, long term. If surgery is required, it's usually for pressure symptoms, tracheal compression, esophageal compression, recurrent laryngeal nerve compression, retrosternal extension, malignant change, or the patient's very anxiety of having a lump over the neck. And of course, if it is a very large goiter, cosmetic considerations become important. Okay, what are the surgical options available for multinodular goiter? Okay, surgery is basically thyroidectomy, different types of thyroidectomy, of which there are 3 types: total thyroidectomy, total lobectomy, and subtotal thyroidectomy. These are the 3 main causes. In the first case, where the total thyroidectomy is done, patient has to be given lifelong oral thyroxine replacement. So they have to be placed on thyroxine replacement treatment. Okay. And also there is a higher incidence of risk to nerve injury in this process, and also post-op hypoparathyroidism. So total thyroidectomy, post-operatively they can have nerve injury or hyperthyroid problems. Then you can bear total lobectomy. Okay, is the next one. That means you remove the whole lobe that is affected, and the other lobe is normal. Subtotal thyroidectomy with TSH suppression by oral thyroxine is one of the most common operations which are done for multinodular goiter. So you remove the bulk of the tumor, leaving behind a small amount of tissue to provide the thyroxine production. Okay, now we come to discrete thyroid swellings, or commonly known as the thyroid nodule. There are 2 types: isolated or solitary thyroid nodule, which comprise 70% of the cases. So in these cases, there's a single lump and a non-palpable thyroid. The second group is known as a dominant nodule. That means there may be multiple small nodules, but what you are feeling is the dominant nodule of a multinodular goiter, and this accounts for 30% of cases. Nodules may be due to malignancy in 15% of cases, due to follicular adenoma 30 to 40%, or due to colloid degeneration, thyroiditis, or a thyroid cyst. The risk of malignancy is higher in isolated solid nodules, okay, compared to dominant nodule. Solid nodule has a higher malignant risk. Cysts, solid nodules and cystic nodules, solid nodules have a higher risk, and in males, high risk in males compared to females, and in young and the extremes of age, very young teenagers and over 50 to 60 years of old. Correct? There are two spikes, young and old patients. These are the risk for malignancy in thyroid nodules. And a nodule is suspicious to be malignant if it is hard, fixed, with nerve involvement, palsy, recurrent laryngeal nerve, or cervical lymphadenopathy. So if a patient has got a nodule, palpable nodule, if it is hard, fixed, nerve involvement, or cervical lymphadenopathy, then the chances of being malignant is higher. Now, what are the investigations you should do for thyroid nodules, especially solitary nodule? Okay, these are the normal tests, thyroid function tests, free T3, T4, and TSH. If you suspect autoimmune thyroiditis, then you do autoantibodies, radioisotope scan, especially if the nodule is, if there is hyperthyroidism, ultrasound scan of the neck for acute needling, fine needle aspiration cytology is the investigation of choice under ultrasound guidance. Others will be a chest X-ray, CT scan of the neck and chest, MRI, and core biopsy. Okay, now we come to some MCQs. Question number 6. Which of the following statement is true about complications of a large goiter? A. Dysphagia is an indication for surgery. B. Causes stridor due to compression of the esophagus. C. Hoarseness causes hoarseness due to compression of the trachea. And D. Causes more florid thyrotoxicosis than a small goiter. The answer to this question is A. Dysphagia is an indication for surgery. Question number 7. Solitary thyroid nodules are most likely to be malignant in which of the following groups? A. Individuals older than 30 years. Individuals older than 40 years. C. Individuals older than 50 years. And D. Individuals older than 60 years. The answer is D. Individuals older than 60 years. Okay, the next group of diseases we will talk about is hyperthyroidism or thyrotoxicosis. These are the four of a few conditions associated with hyperthyroidism. The most common is Graves' disease, which is also known as diffuse toxic goiter. Okay, in this primary thyrotoxicosis, it affects young females more commonly. Diffuse vascular goiter and eye signs are common. Autoimmune disease with abnormal thyroid stimulating hormone antibodies, TSH antibodies. The next group of conditions will be the toxic nodular goiter, which are secondary to some other changes. And these conditions, they are less eye signs, more cardiac rhythms, and overactive internodular thyroid tissue. Then we have toxic nodule, solitary overactive nodule, T3 thyrotoxicosis, and others rarer causes of hyperthyroidism. The clinical features of hyperthyroidism, the symptoms, tiredness, irritability, irritable mood, heat intolerance, weight loss, despite having a good appetite, palpitations, and diarrhea. There are a lot of symptoms, among which the common ones, the ones are listed here. Then the signs will be tachycardia with a bounding pulse, also known as the water hammer pulse or collapsing pulse. Patient appears agitated with fine hand tremors. The palms are usually warm and moist with sweating. You may have exophthalmos or ophthalmoplegia, lid lag, lid retraction, proximal myopathy, pretibial myxedema, and thyroid goiter with systolic bruit. Graves' disease is 8 times more common in women and more in young adults. Graves' disease is usually associated with ophthalmopathy, and is usually due to autoimmune disorder. Okay, these are some of the symptoms of Hashimoto's thyrotoxicosis: fatigue, sweating, goiter, enlarged goiter, tremors, intolerance to heat, changes in mood, and change in bowel movements. Okay, here are some pictures to show you exophthalmos, prominent eyes, a starry look, as can be seen here, bulging, reddened eyes, and a starry look if you view the patient from the front. Okay, these are some of the signs, eye signs that can be seen, and here is the lid lag. You can see the patient is asked to look downwards, then you see there's a lag and the sclera there. So this is known as the lid lag sign. Then other signs are some of the signs are mentioned here, which are usually not commonly seen in many patients. Now, the treatment of thyrotoxicosis, there are triple treatment: antithyroid drugs, radioiodine, and surgery. Antithyroid drugs include carbimazole 5 or 10 milligrams or propylthiouracil or PTU 50 milligrams. Usually carbimazole will start with 10 milligrams 3 times a day, allow 7 to 14 days, usually 1 to 2 weeks, latent interval before clinical effects can be seen. And then once the effect is there, then you maintain it at 5 milligrams 3 times a day for 6 to 24 months. The failure rate of this medical treatment, antithyroid treatment, is around 50%. And side effects of carbimazole or PTU include granulocytosis and allergic rash. The other important group of drugs used in treatment of thyrotoxicosis is propranolol or beta blocker, normally given 40 milligrams daily to reduce the symptoms, the cardiovascular effects of hyperthyroidism, and this acts by blocking the peripheral conversion of T4 to T3. Okay. Radioiodine is another mechanism which is becoming more widely used these days. Radioisotope facilities must be available for this treatment. It is not carcinogenic or teratogenic when used in right doses and for the right age patient. Not for pregnant ladies due to congenital goiter, possibility of congenital goiter, or hyperthyroidism developing in the newborn child. Radioiodine is usually slow response, may need additional doses before you see the desired effect. And this is required to follow up for life and is appropriate for patients above 45 years of age. Then, surgery for thyrotoxicosis is thyroidectomy. Okay. Now here, thyroidectomy, the indications for thyroidectomy: toxic nodular goiter, toxic nodule, and Graves' disease. Okay, which is failed medical control, medical treatment. It is important for patients with going for thyroidectomy, hyperthyroid patients, to prepare them preoperatively. You must achieve an euthyroid state first with antithyroid drugs. Then patient is usually given some oral iodine. It's called Lugol's iodine, given 10 days before the operation to reduce the gland vascularity. These patients have to be pre-operatively referred to ENT for laryngoscopy to check the vocal cords. Thyroid function tests must be done, serum calcium and thyroid autoantibodies. These are all pre-operatively must be done and make the patient ideal for surgery. The surgery done is subtotal thyroidectomy or total thyroidectomy, depending on the size of the gland. Okay, so in subtotal thyroidectomy, which is more popularly done, where the whole thyroid is removed except for 5 to 10 grams on either side. Total thyroidectomy, which I mentioned before, the whole gland is removed, and this has to be followed up with post-operative thyroid replacement therapy. Okay, so in summary, the indications will be, for surgery, will be toxic nodular goiter, toxic nodule, Graves' disease that has failed medical treatment. Okay, this slide shows you the operation of thyroidectomy. Okay, transverse neck incision. The strap muscles are divided, retracted away, and then you get the partial thyroidectomy, left lobe, right lobe. So you do subtotal thyroidectomy, leaving a little bit of tissue in behind. And the wound is then closed. Care is taken to preserve the recurrent laryngeal nerves on either side. Okay. Post-thyroidectomy complications include hemorrhage or hematoma, respiratory obstruction and tracheomalacia, thyrotoxic crisis, which is known as thyroid storm, where there is massive release of thyroid hormones into the circulation during the manipulation of highly vascular thyrotoxic gland, and this results in the various crisis that is known as the thyroid storm. Voice change due to recurrent laryngeal nerve palsy, wound infection, stitch granuloma, keloid, which becomes a cosmetic problem, hypocalcemia due to hypoparathyroidism, and hypothyroidism in cases of total thyroidectomy. And another important condition is your recurrent hyperthyroidism, especially in patients where you do subtotal thyroidectomy. There is a small incidence of recurrent hyperthyroidism. Okay, next we come to question number 8. Which of the following statement is true about Graves' disease of the thyroid? A. It is the cause of ophthalmoplegia. It is the cause for large multinodular goiter. In the past, Graves' disease, sometimes also called Derbyshire neck. D. It is most common in males than in females. The correct answer is A. It is the most common cause for ophthalmoplegia. Next, we come to the neoplasms of the thyroid gland. There are two broad classifications, benign and malignant. The benign tumors basically consist of the follicular adenoma, which is usually in the form of a solitary thyroid nodule, which is solid in consistency. Okay, so this is a benign adenoma, and the treatment is just local excision or lobectomy. The second group is the malignant group, and these can be either primary or secondary. The primary malignant disease thyroid tumors can be classified according to the cell of origin. First is the differentiated follicular cells, DTC. These are the papillary and follicular carcinoma. Papillary carcinoma accounts for 60% and follicular 20%. Together, the differentiated thyroid cancers constitute more than 80% of the thyroid cancers. The second is the undifferentiated follicular cells, which produce your anaplastic carcinoma. The parafollicular cells produce the medullary carcinoma, and the lymphoid cells within the thyroid produce the lymphoma. And together, these three groups of the cancers or malignancies account for less than 20%. The secondary malignant tumors are the metastatic from other sites, especially the kidney and the breast, which are rare. But more important is local infiltration from the pharynx and esophagus. Okay, tumors from the pharynx and esophagus infiltrating into the thyroid gland. Okay, now as for the etiology of thyroid neoplasms, majority of the cases are unknown. But important factors are previous exposure to radiation of the thyroid, if less than 5 years of age during childhood, and these are usually produce papillary carcinoma. The second will be chronic endemic multinodular goiter, which is not so common, but if it becomes malignant, it is usually follicular carcinoma. Okay. And the third group will be the autoimmune thyroiditis, such as Hashimoto's disease, which produce non-Hodgkin's lymphoma of the thyroid. And the last group is the genetic causes, such as gene mutation, such as the RAS gene. So in general, gene mutation, low iodine, and radiation are the main predisposing causes. Okay, the diagnosis of thyroid neoplasms are basically by using fine needle aspiration cytology under ultrasound guidance. This method is reliable in confirming papillary carcinoma. But for follicular carcinoma, the cytology Thy3, follicular cells cannot distinguish between follicular adenoma or follicular carcinoma. The criteria for diagnosis follicular carcinoma is capsular invasion, which is not possible in cytology examination. If conclusive, a lobectomy or hemithyroidectomy should be done and sent for histopathology to look for vascular or capsular invasion. Core biopsy is indicated if only grossly infiltrative in inoperable tumors. Frozen section can be used with lobectomy or hemithyroidectomy. Again, it is not entirely reliable histologically. Okay, here these are the various categories of cytological stages. Okay, next we come to papillary carcinoma, which accounts for 60% of the thyroid cancers. It's the most common thyroid malignancy, common in younger patients and even teenagers. Lymphatic spread to local lymph nodes is the most common mode of spread. Distant metastasis, especially hematogenous spread, is uncommon. Generally, good prognosis with treatment. Okay, so here it is local metastasis to the cervical lymph nodes, level 6 lymph node here. And this picture shows you a solitary nodule here, which is malignant. Okay, then there's something known as occult carcinoma, papillary thyroid carcinoma, the occult type, also known as papillary microcarcinoma. These are small, impalpable papillary carcinomas, less than 10 millimeters in diameter. Majority of them are asymptomatic, and these tumors can be adequately removed by lobectomy or hemithyroidectomy. They rarely present as jugular lymphadenopathy. If they present, then they present as the lateral aberrant thyroid in metastatic papillary carcinoma of the thyroid. They can even present as metastasis to the lung without a palpable thyroid nodule. So they are usually detected on investigation for the lung nodule that they present with. Next is follicular carcinoma, which accounts for 20% of the cancers. Less common than papillary thyroid carcinoma. Again, confirmation is by histological examination of the tumor, not by cytology, by HPE, histological examination, either by excision or by core biopsy. Most likely it spreads by hematological spread. Blood spread is the more common mode of spread. Lymphatic spread less common compared to papillary carcinoma. Hurthle cell tumor or Hurthle cell papillary carcinoma is a rare variant of follicular carcinoma. It is more aggressive and tends to spread early by blood spread. And this is the prognosis of this is poorer than the normal follicular carcinomas. Okay, this slide shows you the staging, TNM staging of thyroid cancers. The tumor is indicated by T here, T1 to T4. T1 tumor and T2 confined to the thyroid. T1 is less than 1 cm and T2 is more than 1 cm but less than 4 cm. T3 tumor is limited to the thyroid, but it is a large tumor, more than 4 centimeters. And T4, when it extends beyond the capsule, doesn't matter immaterial of the size. The N is when N can be 0 when no regional lymph nodes, and N1 is regional lymph nodes metastasis positive, even to the level 6 lymph nodes. And this is the metastasis. Okay. Now, the other one important thing is the effect of age on these patients with cancer of the thyroid. Okay. Only patients older than 45 years of old can have stage 3 or 4 disease. So the disease in younger patients is most of the time is very localized and has better prognosis. Okay. The treatment of differential thyroid carcinoma. Differentiated thyroid carcinoma or DTC. Total thyroidectomy. Okay, next we come to treatment of differentiated thyroid carcinomas. That is the papillary and follicular carcinomas. It can be divided into two main criteria. Larger, the size of the tumor, the T stage, larger than 2 centimeters and smaller than 2 centimeters. Tumors larger than 2 centimeters, total thyroidectomy with cervical lymph node dissection, level 6 lymph node dissection is done, followed by radioiodine ablation and TA suppression for these large tumors. Okay. For tumors smaller than 2 centimeters, these are considered early tumors. Hemithyroidectomy or lobectomy and TSA suppression using oral thyroxine 0.1 to 0.2 milligrams daily. Okay, so these are the two groups of tumors, and in both groups of tumors, thyroglobulin level is used as a marker for the follow-up of these patients after thyroidectomy or radioablation, and also for the detection of metastases on patients after surgery and with TSA suppression. Okay, so for this, he used the TG levels for follow-up. Then treatment of medullary carcinoma is total thyroidectomy with central and bilateral cervical lymph node dissection. In these patients, serum calcitonin and carcinoembryonic antigen CEA are used as tumor markers. And these tumors tend to be familiar in about 10 to 20% of cases. These tumors, medullary tumors, also can occur in combination with adrenal pheochromocytoma and hyperparathyroidism. Okay, and this include the MEN2 type of neoplasia, multiple endocrine neoplasia, MEN type 2A. So in these cases where it is associated with the MEN, then these patients have to be referred to respective specialties for further treatment and management of this MEN type of tumors. Treatment of anaplastic carcinoma, total thyroidectomy if resectable. And in most cases, they are not resectable because by the time they present, they are locally advanced and infiltrate into the surrounding structures like the trachea and esophagus. Palliative isthmostectomy may be done in patients with tracheal obstruction to relieve or decompress the tracheal obstruction. If not able to resect, then may have to go for palliative radiotherapy. Generally, these tumors have very poor prognosis due to local infiltration, lymphatic and hematogenous spread. Thyroid lymphomas are treated as part of a lymphocytic thyroiditis. Okay, the treatment is by chemotherapy and radiotherapy. Radiotherapy is especially for large tumors causing obstruction. If necessary, isthmostectomy for tracheal decompression may be carried out before the major radiotherapy or chemotherapy. Okay, the next group of diseases we'll discuss is thyroiditis, which is actually inflammation of the thyroid gland. Generally, these condition, the thyroid feels hard and painful. Okay, painful is a feature of inflammation. Okay, so all patients with thyroiditis, the thyroid feels hard and painful. There may be initial hyperthyroidism due to stimulation by TSH, but later classically the patients present with hypothyroidism eventually. There are three groups of them: chronic lymphocytic thyroiditis, also known as the autoimmune or Hashimoto's thyroiditis. Second group is a granulomatous thyroiditis, also known as subacute thyroiditis or decurveinous thyroiditis, and these are believed to be due to infective viral infections. And the third group is your Ridal's thyroiditis. Okay, this slide shows you the three types of thyroiditis which I mentioned. The first one is chronic lymphocytic autoimmune thyroiditis, also known as Hashimoto's thyroiditis. Occurs in females over 50 years of age, diffuse or nodular goiter, may have family history and of other autoimmune diseases. Initially may have hyperthyroidism, eventually leads to hypothyroidism. In fact, in some countries, it is the most common cause of hypothyroidism. It can be associated with papillary carcinoma and lymphoma. Usually in these patients, because of their autoimmune nature, the anti-thyroid antibodies are elevated in as high as 85% of these patients. Detection or diagnosis is by FNAC, and treatment is thyroidectomy and biopsy, and if it's in doubt, do a biopsy before the surgery. And this has to be followed by replacement oral thyroxine if the patient is hypothyroidism. The second group of thyroiditis is called granulomatous thyroiditis. It's caused by viral infection. There is subacute neck pain, fever, malaise, and enlarged one or both lobes of the thyroid. Usually ESR is raised, but the thyroid antibodies are negative. The disease is usually self-limiting, but may present as go into hypothyroidism. Usually they take months to recover, and diagnosis is confirmed by FNAC, and the treatment is oral steroids, prednisolone, for severe acute cases. The third group of disease is the renal thyroiditis. It's a very rare condition and is probably a collagen disease. There is infiltration, fibrous tissue replacing the thyroid follicles with local infiltration of vessels, nerves and muscles, etc. So that means this fibrous tissue or connective tissue replaces the normal thyroid tissue. The gland itself becomes very hard, fixed and nodular, at times difficult to distinguish from anaplastic carcinoma. Confirmed by biopsy, and treatment is with high dose of steroids and thyroid replacement. Now we come to quiz number 9. Which of the following features is not consistent with follicular carcinoma? A. Malignant proliferation of follicular cells. B. Follicular carcinomas are diagnosed via fine needle aspiration. C. More common in women than men. D. Commonly have the PI3K-AKT signaling pathway for mutations. And uniform cells forming small colloid containing follicles are seen. The answer is B. Follicular carcinomas are diagnosed via needle aspiration. This is wrong because needle aspiration will not be able to detect capsular invasion, which is a criteria for the diagnosis of follicular carcinoma. Quiz number 10. Which thyroid cancer has the lowest prognosis? Choose the answer that shows correct descending order. First being the cancer with the worst prognosis and the last being the one with the best prognosis. A. Anaplastic, medullary and follicular, followed by papillary. B. Anaplastic, medullary, papillary and follicular. C. Anaplastic, papillary, medullary and follicular. D. Medullary, anaplastic, papillary and follicular. And E. Medullary, anaplastic, follicular and papillary. And the correct answer for this question is A. Worst prognosis is anaplastic, best prognosis is papillary carcinoma. In between, medullary and follicular. We come to the end of today's lecture on thyroid disorders. Thank you for your attention and patience. Hope to see you again in another session soon.